So, ladies and gentlemen, this is a treat. You have an all-star cast here. Never mind that first group that I started with. This is an amazing group, and I'll let Lee Revere sort of introduce everybody. But you have here as the boss, Lee Revere, who's the Director of Interprofessional Education for the whole UTHealth Science Center. That's bigger than Beaumont. It's a big place, and that's, interprofessional education is doctors, nurses, public health, pharmacists, et cetera. Big deal. Also director of the Fleming Center for Healthcare Management in the School of Public Health and associate professor of management and policy at the School of Public Health. So, and I asked her for 3 of her 43 titles, and so but listen, this is you've got all stars. We're talking about quality, and I'm going to sit down and listen. Lee.
Great, thank you and welcome. I'm excited to be here today. I love quality, I teach quality, and I'm on, yeah. And I'm particularly excited because we have a fantastic panel. I hope you guys will ask them all the tough questions. I had the luxury of having some of my students go ahead and forward me some questions, so I do have some canned ones. But this is your session. It's your chance to learn. It's your chance to ask folks who are in it, doing it, living it, leading it, and all of those wonderful things. So let me tell you who we have with us tonight. We have John Bingham. He's with the UT MD Anderson, and he is our Vice President of Performance Improvement. Welcome. We have beside him Ryan Walsh. He is the Chief Medical Information Officer for the University of Texas Health Science Center, Houston. We have Bela Patel next to him. She is the Vice Dean of Healthcare Quality and the Division Director for Critical Care Medicine at the McGovern Medical School. And we have Laura Petersen. Laura Petersen is Professor of Medicine and Chief of the Section of Health Services Research at the Baylor College of Medicine and the Director of the Houston Center for Innovations in Quality, Effectiveness, and Safety. We have Eric Williams. Eric Williams is the Chief Quality Officer Medicine at Texas Children's Hospital, and his role also includes health information technology. And we have Pam Hellstrom, and Pam is the Vice President of Performance Excellence for Community Health Choice, which is one of the largest Medicaid payers here. Okay. So great, thanks you guys. So here was my plan for tonight, but I can be flexible. I have some questions for the panel, and I thought I would start with those, kind of some tough topics. I'm going a little I'm so sorry, have a seat, please. I'm going a little different because I'm going to put the questions up on the screen only because they're long. In true academic format, I'm giving you all of the context and then kind of a question. And then I'm going to open it up to you guys and ask you guys a tough question, see what you think, and then we'll see what the panel has to say about your answers. And at any point, any time, anyone can also throw out any other question. Sound good? All right, so let's get started. So we're talking about quality of care. And I'm going to get Dr. Bingham to lead us off on this tough question around culture. Okay? So we know all healthcare organizations, we're here to seek high quality, high reliability, safe, effective care, right? That's what they're in the business to do. And we know that most providers and most workers are looking to achieve this. However, we also know that every organization is not created equal. So here's the tough question. The tough question is, what is your role at MD Anderson in assuring that your organization provides that high reliability, quality, safety, efficiency, effective care, particularly today when it seems to be all about achieving some metric?
Well, thank you for the question. It's a tough question. I'm reminded when I heard the question about what is my role in assuring quality, about what Edward Deming, I'm sure you've studied Dr. Deming, he made this comment once that if anybody ever appoints you as the chief quality officer, you should resign and run. And his point was that quality and culture really reside at the top in terms of leadership. And it starts in the boardroom, and leaders at the very top of the organization are probably the ones that have the most influence on assuring a culture of safety and a culture of quality. So what I would say is that my role is to support our senior leaders, to give them advice, to call out what I think we're not succeeding at and what we need to do. We just finished, I was telling Bela earlier, we just finished today our Culture of Safety survey. And this is by ARC, Agency for Healthcare Research and Quality. We haven't done a survey since 2012, and our response rate then was 28% of our employees. So today we've had it open for 2 weeks. Our response rate, we closed it at noon, was 86%. And so you might say, well, why is the response rate so much higher now than then? And we're talking 20,000 employees, so it's 86% of 20,000. And the reason is all about leadership. If leadership says it's important, if leadership announces that on day one, our new president did, that culture of safety is really important to me. I want everyone to take this survey. I want you to be honest. I want to know where we are. I want to know what we need to work on. When leaders say that and mean it, that's what happens with a survey response. So my shortest answer then is that I don't assure it. I help along with everybody else, because culture is everybody in the organization and what we all do day in and day out.
Good, good. Anybody else on the panel want to chime in about the culture at your organization or what you do to assure high quality of care? Yes, sir.
I'm at Texas Children's Hospital, and you start off out of the gate trying to assume that, well, we're all in it for children, and getting back at the whole, culture ability and have everyone aligned sort of around that. And I think the biggest piece is if you asked every clinician, well, do you deliver good care? And they would say, well, of course not. I deliver great care. And again, you ask that room of 100 people who's in the top 10%, and 90% of them would all raise their hand with respect to that. But it's really driving back down to, so what do you mean by high quality and safe care, and the different metrics you sort of apply to it. And really, I think what it's really done, especially when you have the culture in the right direction, people have a desire, whether that's just someone who does whatever work at the bedside related to patient care at any level, that they understand that their role is important. And I think historically in medicine, there was a schism between, well, there's what the physician thought and then who cares about everything else. And I think that's significantly changed. I hope I can speak honestly and transparently like that. I'm just joking, of course I can. This is a culture of honesty and transparency. But again, it's getting back and allowing people to perform at the top of their license. We sort of hear that, but getting everyone to realize that they're involved in the outcomes of the patient, and that's really what it's supposed to be about. We can't just say we're patient-centric when we're not really thinking about in those terms, and that really it's everyone's a part of the care team, not just the senior-most person or just the physician with respect to that.
Great. So what do you guys think? You guys all work in healthcare, or you've been a patient in healthcare, had a family member in healthcare. How do you know if you're in an organization that's high quality or that has a culture of high quality? Yes, sir, in the back.
My 81-year-old grandmother was skiing last week.
Skating? Skiing. Oh, excellent. Downhill Olympics?
81 years old, skis twice a year, and she broke her knee, fractured her patella maybe 8 months ago, healthy, just went to Montana last week, was skiing. Got hit by a lift, fractured her patella her pelvis in 3 places. And she was stuck in a hospital, I forget what city in Montana, but she was talking to my wife and I for the last 3 or 4 days before they medevacked her back to Fort Walton Beach, Florida, where she lives, but she felt like she was in a spa for 3 days. She's like, it's been the best food, the nurses are amazing, they had 1 nurse per patient, so it's really not realistic compared to the rest of the world. But in her mind, and I kept thinking in my mind, thinking of HCAP scores and patient satisfaction, I'm like, that is what care, although it's hard to accomplish that level of patient to provider care, but she had nothing but amazing things to say. So I educated her on what HCAP means, patient satisfaction, so she makes sure she fills out that survey for that hospital because it's good for them. But it was great to see someone who knows nothing about the healthcare world, who is stuck in the middle, from Montana to South Florida or North Florida, feel such a great experience at that age, having a good time, enjoying the food, the quality. The nurses loved her. She's the Southern Belle in Montana, ski resort, breaking her pelvis. But so in my mind, that's where I would love to see healthcare culture go, because that culture stems from somewhere, right? It's usually it should be coming from the top down. Hopefully it comes from the bottom up, but it's just a good relative recent experience in my mind that I thought I would share based on what you guys are saying. I think that's where leadership at your level will come on down. That's something you can instill people, and that's the outcome and a good result.
Great. Good story, too. I hope she does well. Anyone else have a question or comment about culture? Yes, ma'am.
Yes, I was going to answer, in answer to your question, how I judge that as a consumer of healthcare. It's really from the moment I open the door of that office, or sometimes even from the moment I make an appointment, how they conduct themselves over the phone and in person. Are they professional? Are they attentive? Are they listening? Or are they, on the other hand, disrespectful, talking over me, with preconceived notions of something? So I'm definitely judging that from the moment I make contact with that organization. And I can tell, obviously, after having met so many people over years in my career, I can tell where the lack is, if any, in some of these medical institutions.
Interesting. Good. Yes, ma'am.
Thank you. Hi, I'm Erin Smith. I think the question is interesting when you look at how an institution handles what is not a wonderful story and someone feels like they're at the spa, because I think that's one way you can really tell how high level the care is, because there will be instances for any patient potentially and multiple patients where it doesn't go the way the chief quality officer would want it to go. And as a patient and someone working in healthcare, how the system or the community within that healthcare system responds and escalates as needed or diffuses or addresses the patient issue, both from a legal and compliance perspective potentially or otherwise, I think really is the difference between those at the top of their game with healthcare or those who are still trying to figure out how to make the age cap, resonate.
Interesting. Yes, ma'am.
I also think it's interesting how an organization integrates metrics into their culture. Metrics don't have to be a concept of fear for an employee or for a part of their culture. It doesn't have to be something that's a punishing piece, and yet sometimes I think cultures use the metrics as a punishing standard or as a stick instead of a carrot. Sometimes they use those metrics as almost as a bar that no one is meant to hit. And yet metrics can sometimes be used very favorably as a motivational tool, as something that is very wholesome and encouraging facet of culture, and it can be meant to be very motivational.
I think it's where the rubber meets the
Reflections?
road,
Yes.
too. It's where the rubber meets the road. So when you ask someone like, well, do you do a good job or a great job or how do you perform? Well, what are those indices when you say you do a good job? How do you describe that to people? So people, I know I'm a good pediatric intensive care clinician because I communicate with families or they respond. Then those metrics are probably different for different subspecialties. We know that. But it's like those types of features matter, as opposed to the org, as you say, coming saying your metric of success is something that you haven't necessarily been engaged in defining. But if you get the people doing the work defining those metrics, then again, to your point, it's more of a carrot and less of a stick, and it matters to them. So it wins on both sides.
Great. We're going to come back to some metrics, too, because I want to hear a lot more about how everyone is defining and attaining their metrics. Okay, so let me go on to the next question, which talks about the trade-off, if there is one, between quality and cost. And so we know there's a lot of discussions these days between high quality and cost. And we also know that everyone says healthcare is just too expensive, right? We're spending too much. And some people would argue we don't really have high quality, particularly for the expenses that we put out there. So we all know this. So I'd like to kind of open this discussion on what is this relationship between cost and quality? I mean, what does that look like? And so I'm going to pick on Ryan to answer this question. And specifically, I labeled the question of what determines how you choose your quality measures for the organization. And Ryan has the UT physician groups under him, so lots and lots of physician practices. So how do you choose these metrics, and how do you really know if I meet that metric, I am a high quality and cost-effective organization?
So there's a few questions in there.
Yes.
So one of the first things to talk about to me is where you're talking about a high quality organization and then cost. And I think a lot of times currently cost and quality don't necessarily have a one-to-one correlation. In theory, if you are delivering high quality care, it should also cost less. But that's not necessarily always the case. So cost is number of services delivered times the quantity of services. So you have to do one of two things. You have to either deliver less services or you have to deliver cheaper services to really reduce cost. We're measured on quality in kind of a different way. So quality is the likelihood that the care that you're delivering or the services that you're delivering are going to help patients or populations achieve a desired health outcome. So for example, if my group of physicians does an extraordinarily good job delivering colonoscopies, that's still quite expensive.
Right.
So we have delivered good quality care, but at a considerable cost. Now, in theory, that should reduce the number of folks that have advanced cancer, that have to go to MD Anderson and have very expensive services. Hey, you guys are trying to eliminate cancer, so are we. So theoretically, those things should tie together. And I don't know that we have the greatest longitudinal data to kind of figure that stuff out just yet. So when you're asking about cost and quality, like I said, in theory, one should equal the other, but that's not necessarily always the case. So one of the places where it's definitely the case, and I'm an office-based physician, like childhood immunizations, no-brainer. The amount of quality-adjusted years of life you get for the cost per immunization is just, it's, like I said, it's out of the ballpark. Certain cancer screenings, you're starting to kind of get, I wouldn't say off, but, further down the trail. So it's not always equal. How do we pick what we measure? Candidly, it's generally the payers that tell us what we're going to do. That's not always a bad thing. It's not always a good thing. Occasionally, if we have excess capacity, which is almost never, we try and make impact. So we say, all right, kind of, what are our biggest issues that are affecting the largest number of folks with the largest health outcomes impacts, and can we get to those? So if we have things left over after the government or a payer tells us what to do, we go there. So I'm sorry I don't have a more complex, more complex answer for that one, but no, I mean, most of that's kind of dictated.
So now, Pam, I'm going to have to pick on you a little bit as the payer representative in the group. So Ryan points out, which is rightfully so, the payers, CMS being the largest, and other payers are often dictate kind of what those quality metrics look like and what the public actually finds out about. So what's your thought on, is that the right approach, the wrong approach? Does it work? What would you do differently?
So I wish payers had the freedom to say, here's what we really think are the best for our members, but we really don't. Coming from a Medicaid world, we are dictated also, sort of, by HHSC telling us what measures they think are important to the populations that we serve. So in Texas, Medicaid tends to be a lot of pregnant women and kids. And so the measures that they put us at risk for are primarily around that. My company will have $25 million at risk this year if we don't meet certain quality measures. We're allowed a 2% profit margin, but we still have $25 million at risk. Now, granted, the measures, most of them are pretty good, although they don't necessarily guarantee good health outcomes. They look at preventive medicine around kids that are 12 to 21, 3 to 6, in their first 15 months of life. They look at prenatal postpartum care, making sure mom gets in early for her first visit and gets her postpartum visit at 21 to 56 days after delivery. It looks at weight control, counseling for nutrition and exercise and things like that. The thing that they've most recently added in is looking at potentially preventable events. And we struggle and say to them, you are holding us accountable for potentially preventable ER events. How does a payer really do that? So a part of what we do is we try to partner with our providers. I mean, we certainly can't do this in a vacuum. So community has a provider incentive plan that ironically is built around those measures that we're put at risk for, and that's the way that we hope we can achieve some of those goals. I also have to say one thing about the quality issue. I really appreciate the story about that person, but we didn't hear about the health outcome. And I came from the provider side for the last 20 years. I was with Christus, and I oversaw patient satisfaction. And it amazed me, the perception of quality with our patients. I used to joke with our providers, you could do a successful heart, lung, liver transplant, but if your restroom was dirty or your front desk person was rude, that particular patient didn't necessarily view that as a quality experience. And so I struggle with the perception of quality with patients and in our case members, and how do we do a better job of educating them about what really is quality. And I don't think the government helps us. I don't think the way that Medicare does the STARS program, and Medicaid's going to go to a comparable STARS program as is Marketplace, I don't think that's really going to help members or patients really assess quality care.
So let me ask you guys, somebody help us understand, what does it mean when Pam said Medicaid is at risk in the state of Texas? I know a lot of you guys in the audience have to know this answer because you've been in at least one class with me. What does that mean? Nobody? Yes, ma'am.
So I'm going to take a guess here.
Take a guess, yes.
Medicaid is a state-funded program for which Texas denied to take federal assistance for. So therefore, I mean, we do have a good Texas economy. We've actually got a balanced budget, one of the few states that does. And I'm about done, sorry.
Okay, all right. We're getting closer. You're right, Texas did not expand Medicaid, but they still get federal funding for the Medicaid they have. So who else? Tobin?
Oh, okay.
Go for it.
My assumption is it's based on your total cost of care, and if you hit certain quality metrics, that $25 million you could lose or you could win based on how the outcomes of that. So.
Good, thank you. So Texas, Medicaid, much like the federal government, puts these payers at risk for attaining certain quality metrics, and if they don't meet the metric, it can be a significant financial loss. So obviously there's a lot of focus on the metrics, just and many reasons to stay in business and be able to have $25 million to then cover other individuals and lives. So it is a tough balance. Yes, sir.
And sort of just to tie in, and I think Ryan, when you mentioned it, you know, it's the quality as defined by the customer, right? So as the patient, you know, they're sort of define their quality metric, but then there's quality in sort of our eyes from a clinical standpoint. Like, well, obviously you would want the best liver, lung, heart transplant, or we didn't cut off the wrong leg, or, you know, that whole issue, right? I mean, that's high quality care. But again, like, what are those definitions? And then who's driving that when the payer who's covering the cost is covering that, but you as the customer aren't? So for example, there's a new drug that came out on the market that helps prevent, there's really rare neurologic disease, and it has all these horrible developmental delays. The early data suggests you don't have those limitations you had before. Super rare, $125,000 a dose. And you get 6 dosages over the first, I can't remember, 18 or 24 months. Large bill. I know we have 30 patients in our health plan that potentially could get that. So if you're the patient and they say like, hey, do you want this health plan or that health plan to cover that? You're going to say, you betcha. You know, but as society, is that where we want that, you know, $1 million a pop for potentially a better outcome? So challenging conversation to have.
Yes, ma'am. Oh, I'm sorry. Let's go back here and we'll come forward. I didn't see you. I'm sorry. Go ahead.
That's okay. I just wanted to get back to that conversation real quick about the $25 million at risk through Medicaid. Who's driving the car on that? Medicaid is a federal-state joint program with all sorts of weird permutations across all 50 states. Is that primarily the state of Texas pushing that, or is that primarily the federal government, or some combination thereof? Any general insight would be useful.
For the at-risk measures that I mentioned, it's entirely the state of Texas and HHSC that drives it.
Yeah, Texas capitates the Medicaid providers. Yeah.
Yes.
So to keep their cost controlled, Texas capitates them.
Yeah. I'm from I'm from Illinois originally, and coming to Texas, and especially with it being a state that elected not to expand Medicaid, when you look at there's two main programs that they use to do a Medicaid expansion here in Texas through what's called an 1115 waiver, and those are the DSRIP, which is Delivery System Reform Incentive Payments, and NAPE, which is Network Access Improvement Program. And actually, Texas is pretty, I would call it progressive in how they do their kind of risk-based contracting for that. And so I think that the payers are kind of, if you will, under the gun to perform and live up to what HHSC wants. I think a lot of times we have a hard time, again, knowing if the metrics that we are trying to incent actually over the long run work or don't work. And I think it's really, really hard for folks that are in the Medicaid delivery side because, so let's say I give childhood vaccines and hopefully I'm preventing that disease, but the real benefit is over a lifetime. And those patients or members are bouncing kind of in and out of this plan. So they're going to eventually retire from CHIP, or they may be in 3 or 4 different payers through that. And so it's really tough. And then what matches what's good for a payer may not necessarily match what's good for the patient. So it's getting the incentives aligned is really, really tough.
So we actually, again, we are required to do some collaborative process improvement projects. This year we could do it with either another MCO or with DSRIP projects, and we chose to do it with DSRIP projects. It was really hard for us to find a project that really had enough of our members involved because a lot of them were originally targeted more towards the indigent population. So when we were looking at various ones that we could use, we looked primarily at, again, kids or pregnant moms. And we would sometimes find that it would be less than 100 of our members. And so it's really difficult to get involved in that. I do think, as you look at the 1115 waiver, though, they're definitely pushing much more where the MCOs are going to be intimately involved in that, just like they are in NAPE. NAPE we were very involved in when they considered it part of a quality project. This year they've decided that NAPE really isn't a quality project, reduced the incentives significantly for managed care organizations, and now we just have a simple administrative cost where we take the funds and pass them on to the various NAPE programs. But we're actually involved in 12 different NAPE projects at community. So
What's NAPE?
Yeah, what is NAPE?
The
Network Access Improvement Program. So my best description, and I'm not, so you are more likely to get it right than me, but it's we don't have enough providers to provide care in this specific area here, and here. Payer go out and contract with service delivery provider to provide this type of care here, and here. Is that
That's
an accurate description?
And additional funding from the state to do that.
So ours is, some of the NAPE projects that we're involved in are everything from working with UTP and setting up a clinic in Beaumont and setting up a clinic in Rosenberg to helping with connectivity to various EHRs so that we can more readily get information and provide faster responses to some of our providers when they ask for and some of those various activities. So they didn't give us a lot of definition of what the projects could look like, but they're fairly varied and really do provide some good services. But I do think that's the direction, is that you're going to see managed care organizations much more involved in DSRIP over the next several years.
So I'm going to ask a question to Laura, just because you're with the VA, and the VA is I don't know a lot about the VA, but the VA is a little bit of a different model because you do own, in some ways, the quality of the care and of the patient through the course of their life, as opposed to, I might be with Blue Cross this week and, Aetna when my insurance changes, or Medicaid jumping on and off. So how does the VA, or maybe just speak to how the VA kind of thinks about this quality cost trade-off, and what if you have the $100,000 medication, and how do you, with a limited budget, figure out who gets it, and how that works?
we not only have a limited budget, we have no budget right now, right, because of Congress. So if you can imagine, Methodist Hospital having no budget, all these months into their fiscal year, it's pretty amazing that you have to run a healthcare system with Congress as your board of directors. But despite that, the VA is a wonderful system. So we're the largest integrated healthcare system in the United States. And as you said, we own the patients. So you're never going to not be a veteran anymore. So once you're a veteran, you're always going to be eligible, as opposed to the majority of health plans that all of us have, where if we change jobs, we could change or lose our insurance, or if we get a job, we might lose Medicaid. So the VA is really an unusual system, and because of that, we really, I think, focus a lot on preventive health care. So when we invest in, cholesterol-lowering medications or other things that have a long time horizon, like you were talking about, we actually can reap some of those rewards. The VA also can do a lot with controlling pharmaceutical costs. So we have an amazing savings that we do by being able to bargain for different pharmaceuticals, and then this is changing, but having pretty strict controls over what I, as a prescriber, can prescribe. I have to go through a lot of hoops to get certain medications, but it allows for controlled costs. And there's a really good process for figuring out what is cost effective. And so I think those are some of the advantages of this large system. There's a lot more choice now too. So because of the Choice Act, patients can also go outside the VA. So they, if they're not happy with what the VA has decided to provide, they can leave the VA and get services outside.
Good. So let me ask you guys, how do you, or what is your thought on, the government, whether it's CMS or Texas or the VA, deciding what is value, deciding on what these measures are and what should be, versus should that be the provider, the physician? Should it be we already heard if it's kind of the patient, we're going to get a lot of metrics on, food and other kind of necessary but not essential things. So what do you guys think? Who should define quality, cost, value?
Hi. I think it can be really problematic from a patient perspective, and everybody is at the table. There's the payers, there's the systems, and there's the patients. And I think one instructive example is the current Massachusetts waiver that they're looking at related to a unified formulary and a closed formulary. And so I'm looking at my friend at the MCO, and I'm sure you're intimately familiar with that. And I think what we've seen there, for those not as close to it, is that for any group of patients with a chronic condition, for example, an HIV or something else, you may have a preferred regimen, or you may have a preferred method for treating something, but there will be patients whose care might be discontinued or disrupted. And so there may not be the right answer of just having it be government, or just having it be payers, or just having it be physicians, but there probably needs to be some system in place that makes sure that each person has a seat at the table, because there are too many people that could really be disenfranchised, and then we lose all the investment we've had from getting them identified and in care.
Good point. Anyone else, or any questions for the panel on this topic? Yeah, Tobin?
I was gonna say it depends a little bit on, I guess, who the purchaser is of the care. So if I'm a large employer, if I'm a large distribution company or manufacturing company, what's going to be important to me is, let's say, return to work, right? So I get somebody, especially if it's spinal surgery or something like that, how fast can we get back to work? Now, for the patient or the employee, that may or may not be important to them. I don't know. But what is important to them, I think, is reduce pain, increase quality of life, reduce disability index. Those sorts of things would be very important from the patient's perspective. So I think it depends what perspective it's coming from, whether it's those that are paying for the care, whether it's the employer, and now employees often have to pay a lot upfront now because of high deductible plans. So now they are more the consumer. So they have more of a voice in quality, I would think. So those who control the resources, I guess, get to decide those quality type of questions and who's paying for it.
Yes, sir. Dr. Garson in the back has a tough question for all of us. I'm going to step out for a moment.
Maybe I can step out too. This relates to the idea of, I'll tell you a little story. Texas Children's used to, I don't know if they still do, had a thing called What's Up, Doc? And they still doing that?
They haven't invited me back.
Okay. Great. I mean, it was a great fundraiser, and it was terrific. And people would decide who they want to have dinner with, and you'd have a long list of stuff. And I was the quality director at Texas Children's for 8 years, and so I had the same question every year: what makes a good doctor? And so every year we'd have 10 fairly wealthy people sitting around the table, and I'd say, okay, to my left, what makes a good doctor? And 4 years in a row, the same sort of thing happened. Well, knows who I am, has a good receptionist. You see where this is going. I can get an appointment. And I'd let it get about halfway around the table, and I'd say, doesn't it matter if you get better? Oh, we just assume that. So the question is around, one of you were just talking about high deductible health plans. It's an article a couple of weeks ago that 6% of people who have high deductible health plans use the quality data. 6. So this is a really, and Lee, you get to answer too, how are we going to get patients actually to pay attention? Of course, patient satisfaction is vital. I'm not saying make it different than, I'm saying add to it. How do we get patients to pay attention to quality data is the simple but not so simple question.
Yes, ma'am.
So, I've done a literature review. It seems like these days with Yelp and RateMyProfessor.com and everything else that patients would really want and desire that kind of rating, but they really, it's pretty consistent that they don't use it. So all this public reporting, the public doesn't use public reporting. And so I think rather than trying to make patients do that, I think we should rethink why we're doing it. So I think there's a lot of reasons that they don't use them. One is that we all can't agree on how to measure quality professionals. We can't agree on it. I mean, I think that's one of the take-homes of this discussion. We've all had a different perspective. And then scientifically, when you look at different metrics, none of them agree. So even for things like risk-adjusted mortality and things, the denominator is different across every kind of metric that you compare. So we can't really agree on simple things like preventable death. How are we going to go further down the train and get things that are even more difficult to measure? So it seems like quality measurement is really more for, not for the patients, but for us as providers. So it's a way that we can think about the care we're providing, improve it, but also it's a reputational asset, an economist would say. So I'm going to argue with you, Tim. I'm going to say we shouldn't be trying to force patients to use data they don't really want. And you think about a very sick person, they're not going to take time to go online and try to, before they call 911. People are sick, they don't feel good, that's why they need a doctor. So you can't expect them to look at quality metrics. So instead, I think we should really focus on us as providers and healthcare delivery systems as being the ones that are looking at these metrics. Sure, they should be available for people to look at, but we shouldn't be trying to get patients to look at them because I think that's kind of a losing strategy.
So We actually did a focus group with our marketplace members and our Star and Chip members to ask them how they picked their PCP and how they determined quality. And the way they picked their PCP was very different for the two populations. Marketplace tended to go online, look at complaints primarily with, WebMD and things like that. And the one that had the fewest complaints were the ones that they tended to pick. They also looked at, did that particular provider speak the language that they, wanted to be spoken to. Our Medicaid and our CHIP members asked family and friends. And so it was really interesting that with Marketplace, where they do have co-pays and deductibles and things like that, they did try to go online, but their biggest dilemma was, we don't really know where to go. And I can read someone that really thought this was a great physician, and two other people thought that the person was lousy. And so you're right, it's really, really hard for someone to determine what is a quality provider with the information that's out there.
Yeah.
Well, another feature is you can go online and you can look at your cardiac surgeon and find out what do they do. But you don't get to pick who your anesthesiologist is. You don't pick who your intensive care doctor, your respiratory therapist, your nurses. And I look at, recently we had 6 cardiac surgeons, 16 cardiac anesthesiologists, 24 pediatric intensivists in the cardiac ICU, 104 nurses. And so when you think about that team that's making those decisions to get you the optimal outcome, is it always 100% of the time the same 24/7, 365? And sadly, it isn't. So to your point, again, until those group of people start to agree and really focus on that, I think that's going to be a challenge.
Yeah,
not to say you shouldn't have some metrics out there.
And I think going back to Tim's point, most people who aren't involved in this business just assume a doctor is a doctor and you're going to get better. That's the whole idea. And so they choose based on things like distance or parking, something else.
Bela?
So I would completely agree with Laura that really the patients really care about convenience because of the expectation, convenience or group referrals, family referrals because of the assumption that we deliver the highest quality care. But I would also say that we as healthcare providers, I don't think we're uniformly vetted in the metrics that we get judged by. And a part of it is, I think it's really our fault, because who gives the payers those quality metrics? It's us in healthcare. We're creating them, we're vetting them, we're making them available as potential quality metrics. And I don't think we've really been invested in developing those high quality metrics, whether it's on the scientific side, or the delivery side, or the patient side. And an example I can give you is I started developing new measures for our national society. And as a result, we took over a COPD core measure, which has been very basic, one of the fundamental core measures that was developed for assessing care of COPD delivery in the outpatient area. And when my group took it over, we realized that the definition of COPD was wrong. So we said, well, how could it be out there for 5 years and not one person complained that the definition was wrong? And so we went on the CMS databases to, look, does anyone ever complain? Anyone give us feedback? And there wasn't a single, not only did no one give us feedback, there was no one ever commenting on the measure. So I would say that we actually then also follow, the payers expect us to follow measures. We follow them just because we're sometimes checking the box, but it's really surprising that we in healthcare have not been vested in what we get measured by. So I think that's an evolution. I think we're really early on how we define quality from the payer perspective, from the delivery perspective. But on the other hand, I do also agree that in the inpatient, especially in the inpatient side, we actually look at really complex risk-adjusted modeling for mortality and length of stay and cost per case. And it's not perfect because a lot of it's based on coding and documentation, but it is fairly complex and sophisticated and probably the best we have out there. Or as we look at databases, whether it's especially specific databases or group databases for adults and pediatrics. And we actually we're learning, and we're learning continuously to see whether we're outliers and how we can improve care. So I think so quality metrics are really valuable for us to have this continuous self-improvement, whether it's individual or systems or the country. But I just think it's such early in the evolution that we're not quite there yet. And so I think consumers of healthcare are also confused as to what to look at. Because when you look at who should I get my cardiac surgery by, it could be that the person that has the lowest score is probably the best surgeon you should go to because you may be the most complex care, right? So we know that, for example, CABG surgeries, if you go to small programs in the community, for example, they're not going to do the highest risk cases because that's not what they do. So when you have the multi-system problems, your heart's not functioning well, your kidneys are down, you're going to go to the most complex centers, and they're going to have the higher mortality. And how do you adequately adjust for that? How do you teach the consumers that point? And I think that all of that is very difficult about quality, and I think that also turns off consumers because they look and they don't understand why, certain physicians or hospitals are highly recommended, yet they would have high mortality, and it's complex. It's a complex field.
Mm-hmm. Yes. Mm-hmm.
So I was thinking, because we mentioned that we invest in the wrong metric system, and so my mind took me back to really what does the lay audience use as their potential source of information on who to go to see, which provider to see. And I know that a lot of people, especially the millennials, would go online and use Google reviews and Yelp and all those other, maybe from a provider perspective, not really the best source, but that's really what people do, especially people who don't really understand scientific information because, they don't really understand. They don't understand the science of what we're presenting. So Google reviews and Yelp and all these other sources are easy to consume, and they're pretty straightforward. Just subjective information on this provider sucked or this provider was great. People understand that fairly easy. So my question is, so should we start investing in those sources, especially when we're thinking from the patient perspective? And because, for instance, those reviews, patients go to them, but how credible are they? How valid are they? Because I know that people actually pay to have people website managers and things like that to actually present those that great sort of reputation. And so patients are misinformed. And so what are we doing to stop this? Because we have to work with the reality of what is going on now. Patients don't go to HCAPs to really see. I actually just learned about HCAPs just this semester. I never knew about it. Most people go to these Google reviews. And so what are we doing about it? That's my question. Thank you.
Let me ask you guys, by show of hands, how many of you guys have gone online to look up a provider, a hospital, a site, for quality, not for directions? Yeah. People are looking. Yeah. How many of you use that information to make a decision for yourself or someone else? Yeah, people are looking. So I think it's a great question. We know that consumers aren't going to the CMS website and looking at risk-adjusted things or worrying about volume. So why don't we do what the consumer wants and have our Amazon star rating with comments, and you can look at the top ones or the bottom. I mean, Health Grades isn't too far from that, but why don't we invest in making those better? Yeah.
So I'd like to just shift the conversation a little bit relative to cancer. So I think I've been in healthcare a long time, and I think there have been a lot of metrics that we've been asked to chase, which are really not relevant for what I think is most important. So in our case, what we would look for is the value proposition. So that would be clinical outcomes over cost. And if you think about what consumers want, if I'm diagnosed with cancer, what I want to know is, what are your outcomes? I don't really care about all these process metrics that you have to track. I want to know what's your 5-year, 10-year, 15-year survival rates, and what's my quality of life going to be like? Can I return to work? Can I vacation with my family? So those are outcomes. So patient-reported outcomes are important, and clinical outcomes of survival, quality of life are important. and then what's the cost of getting that outcome, and then I'll decide about the value. I also want you to pay attention to what I need as a patient. So am I engaged in the decision making? Are you asking me what my preferences are? Are you giving my options? If it's prostate cancer and I'm 50 years old, it's going to be different if I'm getting prostate cancer at 74. Things are different, and I will choose differently based on that difference. So am I being engaged in that discussion? And I think that's what we need to give consumers is useful, understandable data about outcomes, about patient-reported outcomes, what other patients are saying, and what's it going to cost, and then inform me what are my options around this disease. I think we're chasing way too many metrics that aren't relevant to the consumers. Providers should pick the right metrics that drive to the right outcomes, and that's what we should be fixing are those processes that make those outcomes the best that we can make. And we have a long ways to go to get there, but I think that's where we need to be going.
Yes, ma'am.
I do think as far as defining what quality is and how can we help the patient understand what a true quality measure is as far as clinical, which is what we all kind of focus on outcome, I think that should be a responsibility partially for the payers. Only because the patients spend this time picking a insurance plan or their job chooses it or helps them get it, but I know a lot of patients that I speak with, when they're looking for a provider, the first thing I tell them is, to call their insurance company, see who's available. And they've never thought about that. There's a number on the back. They don't know. And when they call, they're just asked, there's, like their area code, like their zip code, where do you live? This is what's there, and go and find them. And I think there's a certain responsibility if a person is paying, or even if they're not paying, they are a part of your plan, they're a part of your community. There should be someone, social worker or someone responsible to at least educate the patients, because that's the first step before they kind of walk into your door sometimes. Of course, some patients go based on some kind of referral and things like that, but if they're part of a plan, Blue Cross Blue Shield, Medicaid, or they're an employer-based insurance, when they get that job and they get that insurance, there should be an extra step as far as the patient should have access to certain information. I have this issue. I'm looking for this type of provider. What do you see with your patients or outcomes? Because it's being measured on your end as well as a payer. That should be, direct kind of service to the patients as they're part of your community and your family.
Interesting. There's somebody in the back that's been waiting, and then I'll come back up here to the front. All the way in the back, and then maybe someone else up here too.
Hi, I'm going to put a different hat on population health. So I'll just give you a little bit of background. I work at the Sobering Center, and we work with public intoxication and the indigent population. We have an 1115 waiver project and developed a recovery program. What we're doing is we've got folks cycling through our system, and we're like, well, where else are they showing up? So we're cross-analyzing their usage of different systems across the city. And I just got a new dashboard on this, Lee, and it's amazing. We had one of our clients use EMS 424 times. Our population is getting transported to 28 different hospitals. We have well over 9,000 visits into Harris Health, and this is 1,700 folks. You look at the jail time for just 28 of our clients, and it adds up to 13 years. So, when you start to cross-analyze the usage of certain populations across the system, there's a lot of inefficiency, there's a lot of waste, they're not getting their health care needs met, and they're driving up costs and with no outcomes. So we're now working to coordinate the care of this population across the community. But getting everybody to talk to each other is really, really challenging. So I would just put on the table that I hope that the healthcare providers start to come up and step up to the plate, because there's 28 hospitals receiving these guys. We've got one hospital that we're looking at data with, and potentially one other. But it's really hard to get the hospitals to start to communicate. But I think from a metric standpoint, if we're looking at state metrics or community metrics or federal metrics, that there are some metrics that would set a bar for everybody, because if you don't set a bar, you don't know how high you have to jump, and get everybody to start talking. That's what the waiver started to do, was to break down these silos, and that we could really reduce a lot of this overuse and poor outcomes for certain populations.
I think that's a really interesting point. I'd be interested to hear what the panel has to say, because if I had to guess, most of these are uninsured, and Texas still has, 17, 18%, depending on how you count it, of uninsured. And so what is the social responsibility? I mean, everybody has their, goodwill to the community, but really what is the social responsibility? And particularly here in the TMC, where we literally can walk across the parking lot and talk to somebody about a patient if we so choose. What is the social responsibility of the healthcare system to save 4,000 admits or ER, EMS visits? That's a lot of money that we could use to help other people with preventative care.
So we recently looked at similar data, looking at our readmissions and understanding patients who came to the ER at least 12 times in a year, so at least once a month. We've had patients, we found they were coming to the ER twice a week within the Memorial Hermann system, and trying to understand why and what resources they needed and so forth. And if we just calculated the cost of just one system and the ER visits for patients who were non-resourced or had psychiatric disorders that weren't able to get the help they needed, we were easily looking at $75 million just in ER cost. And that one patient alone who came apparently came twice a week, and nobody said in a whole year of coming twice a week, hey, how can we connect you to the right resources? So it's about this value proposition that we talk about, quality over cost. And we say, I think we're so used to saying, well, we can't admit you, let's connect you somehow to social services. And those connections are very difficult because we don't really have a systematic program in Houston to connect everyone very easily. And obviously hospitals don't communicate, so it's hard to understand what's really happening, especially in those ER areas. But I think it is, in a way, we're going to have to invest to really save down the road, because if we invest in our communities, we're going to get millions of dollars of savings on the back end. And how do we effectively do that? And so I think there are programs that are starting to develop around the country and are really starting to develop in Houston on how to looking at how to save communities and build infrastructure. And part of this comes out with, and probably John knows as well, is really work that was done in Scotland about how you take communities and you build entire infrastructures from birth to death, and use other resources to provide those services that obviously hospitals may not be able to provide, Harris Health may not be able to provide, but really integrate all those resources in a very effective manner by volunteers. Anything from, great ideas that have come across, that actually is now implemented in Boston, was using the Postal Service to do health checks because they knock on the door every day. And so they know if Mrs. Smith comes to the door, they're doing really well. To delivering medications, to making sure that, especially the frail elderly get their medications on time and so forth. And so how do you really integrate our systems to provide that population health? But I think if we don't address it, I think our costs of healthcare are going to continue to rise because we haven't addressed that basic fundamental issue. But I think we're just starting.
Any other thoughts from the panel? It's a tough question.
No, I think, so this goes to, I think it's a kind of a buzzword in healthcare now, is social determinants work. It's always been sort of a hot topic, if you will, but over the last few years, it's really kind of picked up steam. And I think like the throwaway stat is something like 80% of the health outcomes are determined outside of the four walls of healthcare. And if you think about it, that makes sense, right? You don't spend most of your time engaging in healthcare. You spend most of your time doing other stuff. So that's actually one of the interesting things I think that we have going on in Houston. We're actually working with Texas Children's, UT School of Public Health, Memorial Hermann, Houston Methodist, and Harris Health to do a demonstration project with CMS called the Accountable Health Communities Project, where we're going to attempt at least to look at the need for various domains and the social determinants and see if we can help navigate patients to what the community already has and see if that makes a difference in their outcomes. But it's kind of the really organized, well done, if you will, looks at that, I think, have yet to come. So there's little pockets of it that are out there, but it's not really organized yet. It needs to be.
Eric?
And I think what's being leveraged to actually do that is our access to data now, through the use of technology. Because think about it, where did you have a repository that you could manage that had that type of information in it? So the episodic care, patient comes in, oh, sick, yeah, that's fine, I make them well, or whatever, you heart failure issues, you sort of fix their episodic problem because we got paid for that. But beyond that, in terms like, well, you're not going to get paid if they come back into your hospital in 7, 14, 28, whatever, you have to have some sort of plan sort of around that. But now, all these social determinants or all these other things, all the information you're going to collect from wearables of people walking, not walking, to better determine what are the things that are really determining the populations who are at risk, so then you can actually reach out to them. And so I think that we have an unprecedented opportunity to start to leverage that data, which is going to require more work.
Of course, and somebody to fund it. So I want to ask you guys, who should pay for this? Because it's a great project, the Accountable Care Organization. I know a little bit about it because my friend's the PI on it, and it's a great project. The government's funding it through a grant. What is it, 5 years or some, multi-year, and then it's going to be sustainable. Medicaid waiver, it's going to be sustainable. I mean, I don't know. So who's going to pay for it? You guys are a bunch of smart people. I don't know the answer. You guys are a bunch of collectively smart people. We have 6 organizations up here. Who's going to pay for it? Yes, ma'am.
So it's my understanding that the UTHealth Connect, as Switzerland, is dealing with data exchange. And so that now that people are playing together with each other, maybe there could be some thought leadership among those organizations that are allowing data to go from yin to yang, and start thinking of maybe some broader issues where now that they're playing through Switzerland, maybe they'll continue with other projects in Switzerland. So that may be just some other agenda bigger than just allowing UTHealth Connect to be Switzerland. That's just a thought.
No, I think that's a great idea, and they do have a lot of data and data sharing. Who pays for it? Do you know?
Well,
it's all about the money in the end, right? Somebody's got to pay for it. I mean, I hate
the last policy meeting here last week had mentioned that as nonprofits, there's a requirement by nonprofit healthcare organizations to be dealing with public health. So I would think that there's some mandate with the set aside of projects for that. So maybe that needs to just be better organized and coordinated, because we have a lot of nonprofit organizations in the TMC in this part of Texas. So that might be just something that y'all have to come together on, and besides the grant's a great idea, but there may be other programs. Thank you.
Yeah, what do you guys think? Everybody does a community needs assessment and spends money on the community, but how does that go?
And this is the biggest understatement of the evening. This is the challenge, right, of how to prioritize all this. So what you just said, so let's use the example of the community you described in the back there that you're for the Center for Sobriety that you're working with, like leveraging that data, right? So that's a community of people who are disparate, it's centralized in that domain. But yeah, wouldn't it be great if all the institutions, so whenever they touch that organization, that information was collected. So that helps out that population. That no one would say that that's a great idea, we should totally work on that. But what if I told you that we had a way to develop, I can predict if that child after the operation is going to arrest. And if I can prevent that arrest, I can prevent potential neurologic injury, et cetera, et cetera, et cetera, through use of predictive analytics, and that's all the stuff where that's going. Oh, that sounds interesting too. So how do you decide between the two of those in terms of an impact? Because no one's going to say, don't work on that arrest prediction model. Right? So again, how do you invest that, and who decides that? How do you come some sort of agreement on it? Because again, at the end of the day, it still costs money because they're both highly interesting, useful, potentially impactful for outcomes which we're trying to drive. And I think that's the challenge. So I haven't answered the question other than saying, like, it's not easy, but until the right people get engaged to make their voice heard and say, like, no, this is important to us because, whether it's finding, I want my insurance company to know it all and decide where we need to go. I think that's the challenge, but at least having the discussion so people are in it.
Yeah.
One thing from an informatics perspective is, first of all, one of the places where so first of all, what I would say is until people So patients through, I don't know if it's legislation or talking to the folks in power, really demand that their healthcare providers are held to account for their community benefit pieces. Because I will tell you that the community benefit assessments that are done, or community needs assessments, they are mostly done to check the check boxes. So, I mean, there's companies that their whole business is, for X $100,000 per 3-year period, I will write your community needs assessment, which will be promptly placed into a nice little binder and then stuffed on a shelf and never ever looked at ever. So that's usually how that goes. And until somebody's kind of forcing the issue, I don't think that that's really going to change. That's probably pretty cynical, sorry.
No, well, so I always had a question about the community needs assessment. You're in the same community. So why does every organization spend hundreds of thousands of dollars every 3 years to do their own community needs assessment?
Just the cost that we spend on the paperwork to do the community needs assessment is
everybody
pretty
sign
absurd.
it, up it goes, and spend $1 million on helping people get sober.
I was going to say, aren't the CFOs of each organization accountable for signing the financials and the budgets that they approve, and therefore the CFOs know, or should know, what the cost of this is and what is really the benefit of that, if at all?
The community needs assessment? Yeah. Well, it's required. They have to do it by law. So, but yeah, how the money gets spent once they determine what that amount is, I don't know how that decides.
How you determine what is actually charity care versus what doesn't count, and what's community benefit versus not is really, really complicated. I'm not sure that that's not on purpose, but the other place where I was going with that though, in as far as Greater Houston Health Connect, where I think we've missed the boat, is there's 2 models to participating in a health information exchange. There's opt-in and opt-out. Most successful health information exchanges do an opt-out. So you have to actively say, I do not want my information exchanged. Greater Houston Health Connect is the opposite, so it's opt-in. So our participation rate is, last time I checked, is still somewhere below 60%. And then typically, it depends on which organization you're with, but there's always, I call it the HIPAA monster. So there's, everybody has a chief privacy officer, and if you accidentally share one piece of information that's somebody doesn't want shared, there are very large lawsuits that occur afterwards. Point being, I think though, if people really understood how much, in my mind, harm occurs to them because of their privacy with regards to their health information, I think that there'd be riots in the streets. I mean, and that's what I do all day, every day.
Why is it opt-in and not opt-out? Just the way it was set up?
I think honestly, it was they elected for that to get the participation of most of the major players. I think they were more comfortable with it at the time.
It's Texas, yeah. Yes, ma'am.
Hi, I was looking at a paper the other day, and I think it's really exciting to hear about the National Academy of Medicine's work. It's called, there's a document called Effective Care for High-Need Patients. And so they've developed a taxonomy. So as you were saying at TCH, there's multiple categories of individuals, and that really may be what's going to happen with this multi-prong approach. So you're not just saying, well, only this group and only that group, but for CMS and for those large governmental payers to take that multi-prong, because that's what they're doing with all of their models that they're testing at this time. So I think that makes some sense, because there are a lot of groups out there, whether it's children with medical needs or it's individuals with behavioral health. I mean, there's a lot of different categories in that taxonomy of need.
Good.
Yes, so someone, I think maybe it was you, said, well, who is going to pay? We are all paying, okay? When these people are going to the ER twice a week, we're all paying for that. So you're paying for that through your taxes, or you're paying for that through your health insurance premiums that have to cover all the care that Memorial Hermann can't get reimbursed for.
That's a good point.
And I think if we really are going to get toward this holy grail of outcomes, we're going to have to change the incentives so that it makes sense for people to pay for outcomes. And right now it doesn't. And I think, so I'm aware this is Texas. I'm really not from here. And I think, you can see that I practice in the VA. It's the closest thing that we have to universal health care. And I do that for a reason, because I don't think that the incentives that we have now are the right incentives. The VA has incentives to invest, to have programs for homelessness, for drug use, and all these things that are very hard to get in the private sector. So is the VA perfect? Absolutely not. But unless we change incentives and we start recognizing that we are already paying for all of this uncoordinated, wasteful care, and change that with a different payment model, nothing is going to change, and we're going to be sitting here in 10 years having the same discussions. So, if you want to riot and throw things at me, that's fine. But, thank you, Eric.
Protecting you. Such chivalry. Do we have a question in the back? Yeah.
Sure. So you're not from here. I'm really not from here.
Yes.
And I come from a place that has universal health care. So I'm bringing a slightly different approach to this. And given how intractable some of the issues are between public and private, not-for-profit, profit sector in the United States, one of the ways in which government can incentivize this is to look at other models like social impact bonds, to find ways to prioritize funding and drive what America is great at, which is investors and others driving the kind of performance they need to get results out of systems. It's a market-driven approach to what we've tried to do with regulation in this country for a long time, but it certainly would, given we see international evidence that supports, comprehensive primary care physician stated conflict, and risk sharing models where I work, which allow me to both deliver good care and get paid well for it, which those kind of models can be funded innovatively through things that don't require increases to the tax base, because health is a pretty good place to invest. There's a lot of money that circulates in this system, and there are investors who will look to health in the long term as ways in which it both has a monetary payoff and has a long-term social payoff.
Thoughts? Yes, ma'am.
I wanted to add, I think, on the comment about who's paying for it.
There's one more in the back. We're confused.
Thank you. Just to add on that, I think what we've seen in Texas and then the other states that I work in, we've seen a shift from the state portion or share of Medicaid or other payments to the local level. It's kind of a shell game because we are all paying for it, right? Whether it's state or local. But across the country, so many state budgets have challenges. Even though we have a balanced budget, we're still going into the next session looking at a very significant deficit. 2/3 of the states are looking at a similar kind of deficit going into their legislative sessions. And so I think the one thing we know is that it won't be funded by states. What I think that creates is the opportunity for systems like the ones that all of you work at, and then on the private side to figure out, we know someone's coming twice a week, right? Because you have those dollars that have been paid out. So how do you realign and re-incentivize that? Because the local level is probably the only place where you have people close enough to speak. And I think the bright, point I would end on is that the current administration at CMS has been very open to waivers and looking at other types of authority in a very different way than we've seen previously. So if we're looking for a silver lining, that's probably it. And hopefully it incentivizes us in the room and all of you to have those conversations and to figure out what the answer is, because it will probably not in our next 10, 20 years come from the state level. It's just not there.
Good. One in the back and then back up here in the front. Adele? Yeah, you go.
So you guys have been talking about a lot of kind of dancing around this idea of competition in the United States in contrast to other places where they speak the Queen's English, say, for example, Australia. We focus a lot, we just kind of take competition as this article of faith that this is always going, if we compete against each other, we're always going to improve things. And I was kind of curious, based on the gentleman next to me, he's talking about, the government's driving this through putting some mandates down and forcing some market-based competition. We have a little bit more freewheeling sort of competition. We talk about insurance companies competing against each other's, providers competing against each other's. And in some places, we don't necessarily have a ton of competition, like, for example, the VA, Dr. Petersen's talked about, though we're getting more of that in the VA with the Choice Act. So my question to the panel is under what circumstances is competition going to help us cut costs while improving quality, and under what circumstances is competition hindering that?
Yes, Eric?
I think you have to compete on outcomes, and then it gets back to based on whose definition of what it is. So if you're competing on good food versus you cut off the correct leg, but I think that's going to be, you're competing on minimizing your harm, injury, those types of features that I think are critically important with respect to that. Which makes sense. And to your point, so how can we innovate to do that with quality, good outcomes over cost? So we could be very ingenious and harness the power of technology to help do that. And that's where I think if it was driven with the right incentives, because use the health information exchange. You're incentivized to put in a health information exchange, but are you incentivized to actually use it effectively? What does using it effectively look like? Do you exchange all the data? Maybe there's only 2 pieces of data that actually matter for the outcome of the patient, so why do we need all the extra stuff? And now, since I'm on my soapbox, what about incentivizing the technology companies to actually communicate? You talked about us not communicating. So what if, there's no mandate on this company until we start to get some rules around, well, wait a minute, shouldn't all that technology communicate so that we don't have to then invest in a new system on top of a new system on top of a new system to communicate? Why can't that platform be predicated or regulated? And what about Apple's entry in Amazon and the partnership that they just came out with? That's going to revolutionize so much of what. Think of all the well care that we're like, Alexa, should I go see the doctor? Right? That's all going to get pushed out. The simple stuff, right? And what's going to happen in the hospital? All the stuff that you can't do in your house, right? A lot of that information that's ubiquitously available is going to be available for people to use and abuse, but that's going to happen. Sorry.
I was going to actually mention that about, so basically what he's talking about with Apple, if you're not familiar, is Chase and another health company.
Berkshire Hathaway and Amazon.
Have all gone, formed a coalition, for want of a better word, to cut out the insurer. Because that's where a lot of the money's going. It's costing also a lot in private business with employing coders, office people, and medicine has become very concierge now, even in our hospitals and clinics, because of HCAPs too. I do agree with you that, if your bathroom wasn't clean twice in a day, but you really got a great heart transplant. And we are dealing with those kind of issues, but everybody's expecting a very high standard. I was just wondering what it would look like. I think also in the world's largest medical center, we do have very healthy competition between all our hospitals. We have lots of institutions of excellence here with MD Anderson, Memorial Hermann, Methodist, and many others that I'm probably leaving out, and everybody's striving in the area of research and technology. But how do we talk to each other as far as technology goes? Because everybody's still after the money. Everybody's kind of wanting a piece of that. So I see again as the money is kind of the problem. The other thing I just wanted to comment on and wondered what the panel would say would be the Australian, Canadian, New Zealand systems that are socialised are starting to move more towards the American model, because the systems are good once you get into them. But access is limited. They have waiting lists, that whereas here you can pretty much, dial up your operation, go see your provider and get in and have things taken care of. So what would the panel think about the meeting between socialized medicine and the system that we have now?
Anyone? No one wants to say it. You gave them a politically charged question.
I think there needs to be a meeting.
Yeah, you know, the end is probably going to be somewhere in the middle, ultimately, where, or, you know, 2/3 one way versus the other, that to adopt some features of each of those that's of benefit. Again, but again, if it's not driven by that outcome, that patient-driven outcome, I think we'll still have a challenge. If it's just, I'm going to jam this technology into place and figure out later where it's beneficial. I think the strategy has to drive everything. And if you don't have that and you're just, well, we just keep doing what we're doing because, well, we seem to make money. Texas Children's, we build buildings and just keep growing. Okay, well, wait a minute. There still has to be some other strategy based on, well, how do we realize the value of the digital infrastructure in the face of that, recognizing that any building you put up, you don't have to 18 months later rip out all the brick and mortar, right? Whereas your digital infrastructure, they're like, I want this. You want your iPhone experience or your Android experience, you know, press a button and the solution happens. You want that in healthcare now, right? Mm-hmm. So then we're having to try to deliver that, and there's a dollar value tied to that too. So how can we learn from each other? So I'm not competing with him for PICU patients, right? Because we're full and they're full, right? So it's not a question of that, but how can we learn to use the technology to aid in that?
What about telehealth? You know, Amazon's probably going to use telehealth because of FaceTime.
Yeah,
sure.
I think one of the most interesting, here's another throw-out stat for you. So the guy that heads health IT for Kaiser just talked at the School of Biomedical Informatics last week, and they did, I believe it was something like 40 million visits in the offices last year, and not a joke, 50 million via telehealth. Wow. So they're completely upended from, and I don't know that there is much of a robust telehealth. I mean, everybody's kind of dipping their toe into it here in the medical center, but not really. No, certainly not. But when you look again at how the incentives are aligned, so Kaiser is a completely closed system, right? So the dollars in, dollars out, they're equal at the end of the day. They're motivated to deliver care, good care, at the lowest cost center, if you will.
Yeah, and so again, going back to incentives, the VA has a lot of telehealth. So at iQuest, we have a wonderful group of investigators who are doing tele-mental health into the home. So this is for patients that maybe have severe anxiety or PTSD, or they just don't want to drive in Houston traffic. They can get this wonderful service in their home, in their jammies, on the couch. And the VA is incentivized to do that, right? Because the incentives are aligned. So going back to your point about, no, it's not, socialized medicine isn't perfect. The VA isn't perfect, but there you've got to modulate the incentives. So the incentive when you have a global budget or capitation is what? To stint on care because you've got to save money. Well, then you've got to put counterbalancing incentives in place that tend to balance out that incentive. Right now, in fee-for-service, what do we have an incentive for? To do more, whether it's needed or not. That's not high quality. And what does it do? It ratchets up our budget, going toward health care. So it's very logical, and the incentives, the way they play out. So we just have to be smarter about what the incentives are and target them toward population health, prevention, doing things that are patient-centered and cheaper. It's doable. It's just that we're not doing it.
Culture change.
So I've been given the 5-minute warning, and I'm going to ask my panelists to each give you one takeaway that's unique. So what's the one thing you want this group to go out and know about all the wonderful things you, your organization, others are doing in the realm of quality, or something maybe they could do to help? It's tough. I didn't tell them I was going to do that. It's kind of the professor of me. Good, yes.
So I would, if you're in healthcare, I would recommend that we figure out how to apply the concepts of high reliability to healthcare in a very robust way because we are far away from what high reliability looks like, and I think we can learn a lot from other industries by applying those principles to healthcare across the full continuum.
Anyone else? You don't have to go in order, Ryan. There's no pressure.
So I was going to say exactly that. If you take a basic principle of high reliability, which is preoccupation with failure, I think that just that simple concept, whether you're a medical student or a nurse or other healthcare provider or touching the healthcare field in any way, we see failure all the time, but yet it becomes status quo. And I think the one thing I would say from that, as a takeaway from that point, is that preoccupation with failure, we should train medical students, we should train nurses, we should train all of our healthcare providers, and to not only identify it, but engage with the healthcare systems to then help redefine it, develop new systems and so forth. But without that engagement from everyone who touches healthcare, from leadership to frontline, we're not going to get where we want to go as fast as we want to get there.
Good.
So just to continue with the high reliability theme, so that sort of final principle that everyone kind of gets squishy, that resilience, right? So it's not personal resilience, but system resilience. And recognize that every day there are amazing outcomes that happen at all these institutions chronically, but we never measure those. And we don't truly understand why they happen, right? Because if I told someone, said, like, I need to study why we're so successful, the CFO would say, like, you're ridiculous. Of course, it's because we're great, but we don't really know, right? But what happens is on every day, there are people who adapt in the moment and do the right thing for the patients, and we never learn what they're actually doing. And so then we have these standards of care, and then when a bad outcome happens, we investigate and say, like, you didn't follow policy XB247, there it's in this book right here, don't light patients on fire, whatever your thing is. We've not done that, I'm just saying that, but you look and they say, oh, you didn't follow the policy, there's the problem, we educate to the policy, problem not solved, right? And then 12 months later, a year later, that same experience happens to someone else because we don't understand people's resilient, adaptable behavior that leads to everyday success. So figuring that out is challenging. So good luck.
Yeah. Anyone else have a tidbit of wisdom?
Well, I guess I'll go next. I'm really torn between two things. One of the things that we're really trying to deal with is what we're calling our primary care vision. It's helping our members understand the right care at the right facility at the right time. I think that that's a big education piece that we have. One thing we didn't talk at all about tonight was really about value-based purchasing. And obviously, coming from an MCO, that's something that's going to be critical to our success. When we asked who should define quality, I'm pretty sure I don't want it defined by HHSC. That's my biggest concern. It's really the people that are up here that should be making those definitions ahead of time. But we're being pushed into value-based purchasing by HHSC, and we have certain requirements that we have to meet in the next 4 years where, we move away from our traditional model, fee-for-service, the more you do, the more you make, into where providers are now incentivized that if they do have quality outcomes, whatever those look like, that they will get a little bit more of the payment. My fear is, what will that quality outcome look like? Because some of the things that are proposed right now really don't have very much to do with quality.
I would just encourage people to figure out the financing system because the incentives drive what happens. And so if we can have a totally different conversation in this country about who's paying for what and why, and do we want to continue to pay for the people that are going to the ER twice a week, and do we want to pay for people that are floating around through all of our institutions and getting no improvement in their health? And then figuring out what to do with that money that would avoid those outcomes.
Okay.
So I'm going to agree with Laura in the sense that, so I'll throw out my first cheesy quote, which is Einstein in saying that the definition of insanity is doing the same thing over and over and expecting a different result. And so on the incentive system, I mean, candidly, we are incented to deliver bad care. So the more somebody, if you get a complication after your surgery, you get paid to fix the complication after the surgery, although that's getting a little bit better. still, you pretty much get paid to have that happen. Or in the offices, you know, if we see people over and over and over again, you still get paid for that. So until indeed we switch to paying for things that actually should make a difference to the patients in a positive way, because I would posit that, you know, actually, so Bela and Eric get to live in the worlds where they're in the intensive care unit, they take care of people, it's really highly intense, you have to have the high reliability, high stakes, but they get better, hopefully they get out, they go on to live a quality life. So your interventions, most of the time, are going to deliver improved quality of life and improved quantity of life, where I feel like often the services that we deliver aren't just not good for people, they're actually bad for folks. And so, I mean, it's the old Hippocratic oath of doing no harm, and I think that we frequently do harm, and we're just now starting to get to the point where we aren't. And then the last quote is that you can always count on Americans to do the right thing after they've tried everything else first. That's Winston Churchill, so I'll leave you with that.
Well, thank you guys. A big round of applause. Very, very informative. Thank you all for your great questions, for your attention, and we appreciate you coming out tonight.